Co-chair is Mohammed Amar, is already there. Thank you, sir. And I am Dr. Tanveer, the moderator of this session. So we have sort of multiple presenters presenting on various aspects of anterior segment, and that includes ocular surface disease and cornea as well. So it's a mixture of things. First presenter is Mustafa Kamal, and he's going to present on hidden untold stories about corneal transplant. So let's start with these stories. Mustafa?
Starting with the success stories like PK post 6 years, the vision is 6'6" with this much cylinder. The suturing techniques, this is the single interrupting suture, 137 cases I have done so far. Different results and post-operative pictures of my patients. Starting no talk suture technique, and I am so happy that my teacher Dr. Tanveer Chaudhary is now doing it after seeing my results. Dr. Tanveer is my teacher and he has taught me everything, whatever I am doing. And no talk suturing gives you less amount of suturing, proper rehabilitation, and very good approximation. This is what my experience is. I have done 462 cases so far. So these are some post-op pictures of my patients. This much of cylinder, which is actually acceptable by patient when we prescribe them the spectacles. Usually patient go for PKP and they end up with contact lenses for the visual rehabilitation. So these are the cases. So the range of astigmatism was zero point 0.5 dioptric cylinder to 5, and average SIL was minus 2.5 in the no talk suturing technique. So these are the so far records made by me in Pakistan, like 12 corneal transplant done in one single hospital same day, and 100 cases of transplant in a month. So we always talk about the good things. Now, which is DELC with 6.6 and which is CXL with B12 best corrected visual acuity? Nobody can figure out from the both eyes. Which is the DELC eye and which is the CXL eye? Which is transplanted eye with best spectacle corrected 612? Which is transplanted eye with 6.9 vision? With 6.9 vision. 11-year-old kid right PK done 612 vision from Afghanistan. This is not the rejected graft. This is the see-through of the cataract, and this is the LDK done on the Afghan patient, 1 year post-op. So wow, wonderful results. LDK, you can see here how much this is anti-staphloma, and the end result came for EV session. This is a young boy who had bilateral contact lens keratitis, and he then came for the EV station, had an opinion. I managed therapeutically, and then I did transplant. He developed cataract, and then I did cataract surgery on this patient. So this is the 612 post-op vision on the first day. Happy patient. So goals are all achievable. We are all ready to only share our success stories, but one day next year I hope so I would come with this physique inshallah to lower ophthalmo. So smaller steps and goals all can be achieved. So what about those cases which we do not show, the untold stories? Number one, punctate erosions over corneal surface, 7 months post-op, bombardment of the so many medications, reduce the medications so that patient does not have drug toxicity. Epithelial defect, 4 months post-PK. So these are the things which should be managed, which should be told, what are the causative factors and how should be they managed. Epithelial rejection might be viral. Most commonly, it's viral in our part of the world. Herpes causes such sort of rejections in our patients. Example 3 and 4. You can see here, example 3 and 4. This is the post-op patient. How do we manage? How do we do LDK? What are the parameters? What are the things which should we tell the residents and juniors that not to commit those mistakes? This is the another post-op example 4, the LDK, and done very well. So this is the Frera ring, which is rarely used here in our part of the world. I haven't seen. I started using it myself. And what's the importance of it? If we are doing PK on a aphakic patient, so it's very difficult for a surgeon to go for corneal suturing if he's doing on aphakic patient PK. So furring is very important. You should use it in front of residents so that residents should use that one in their lives. Here you can see very clear graft, but too much tight suturing. The patient has -14 of dioptric cylinder. 6 weeks post-op. So we took patient to the theater and we resutured the cornea. So this is the example 6. Post-operative, when we do corneal transplant, there are so many different types of pupil shapes we get post-operatively. So how to manage them? Correctopia, posterior synecdoche, fixed mid-dilated pupils, and peripheral anterior synecdoche, iatrogenic correctopia, dyschorias. So these continued different size shapes of pupils. So this is the main picture, which is the iatrogenic insult caused to the eye. So when we are doing trephination, when we are making buttonhole, then we apply a lot of pressure over the trephine and then we cut through the iris. So this is it. And here, this is the insult caused by the corneal scissors. When we are cutting the cornea with right and left corneal scissors, then we have such insults. So we have to be very much careful about if we have not got the through, if we haven't went through the corneal section and we are doing it with corneal scissors, right and left corneal scissors, then we should respect the tissues inside the eye. So this is the example of LDK, the large diameter keratoplasty. Cataract was found intraoperative and it was also checked on anterior segment OCT, but deliberately we don't do it when we are doing large diameter keratoplasties, because in adherent leukomas and they are wide to wide, they have got iris stuck on the posterior surface of the cornea. So we want something to give a tamponade to halt the suprachoroidal intraoperative complication. So when the iris is not there, I prefer that the mature cataract would work to hold the suprachoroidal hemorrhage at the backside, so it does not come up. So I don't do cataract surgery along with corneal transplant in LDK patients if they have got cataract. But I respect the anterior capsule, I respect the other tissues and the structures in the periphery. Same cases. So tectonic PK due to keratitis. Post-operative, there is hypopion. This is not actually the hypopion. This is the intravitreal antibiotics given intravitreally during the surgery and the patient was well. So post-PK trauma, pre-operative vision. Before the trauma, it was 6/18 best corrected visual acuity. So patient was actually coming to me to get the sutures out after 1.5 years. And then outside the hospital, their kids were playing cricket. So the cricket ball hit the cornea and the patient came to me in the clinic with this condition. So this just happened 5 minutes back outside your clinic. And this was so you can see here, the very clear cornea and vision was 6/12. This thing happens. 5 months post PK, anterior segment OCT, patient was absolutely fine. These are all my own cases. Suddenly he came to my clinic, Dr. Saab, my vision got down. I came to you last week. So I saw it on slit lamp examination. The endothelium was not there. So totally digit. So I asked him to go for the anterior segment OCT. This is what. So I was thinking that what actually happened. So we got multi images of the anterior segment OCT on anterior machine, which we have now in Karachi. So this is it. Here is the insult. So there might be few reasons. If number one is that reuse of the already used trephine, and number two, when we are preparing the cornea, when we are preparing the donor, we should not rotate the trephine itself. The trephine should be pressed over the Teflon block and the cornea, the sclera should be rotated. If we rotate the trephine and the endothelium is already little bit insulted there, so that goes off. So this is what I think. So I would ask my seniors to teach me if there might be some other reason of this case. This is very rare and very dangerous thing. Anything from residents. Suprachoroidal hemorrhage. So suprachoroidal hemorrhage occurs in those patients who already had the history of multiple intraocular surgeries. So before, if any patient has got such history, we should go for UBM, we should go for anterior segment OCT, we should go for B scan, and it is more common in those patients who have got more adhesions in the anterior segment. So during the surgery, we should respect these tissues. We should not completely make a buttonhole in such eyes if it got, because if we are making buttonhole through and through, we can injure the inside, the intraocular structures, and suprachoroidal hemorrhage can occur. And the most common cause in our setup is that what I have noticed, that suprachoroidal hemorrhage, anesthetist tells us that sir patient is ready for the surgery. So when we touch the cornea or eyeball with forceps, eyes goes up or eyes goes down. It means patient is not deep. So and when we call anesthetist, it comes, sir patient is not deep. The eyeball is moving down and up. Then he comes and he just does something and says, sir, okay, you can start. So this is not right, because we should wait for at least 20 minutes. If the patient is not deep and if the patient has got some eyeball maneuver because of the instrument touching, we should wait for 20 minutes, because the maneuver of the suprachoroidal hemorrhage or the Valsalva maneuver is already initiated. So if we start doing surgery immediately on anesthetist instruction, we can have trouble later on. So this is the main key factors. So ultimately, patient lost the eye. So this is the warrior real ones and not the artificial intelligence one. Thank you very much.
So, is it working? Yeah, yeah, you're absolutely right. I've got some of my patients who have had wonderful clear graft and then they suffered trauma um, one way or other, and the ball injury is very common. I think the reason being uh, in our part of the world, cricket is being loved, and children play cricket all over. There are not enough grounds available, so they play on the streets, and passerby injuries have been noted not only in the corneal transplant but otherwise as well. So, moving on to the next talk, uh, Dr. Tayyip Azim Janjua, two cysts in one eye pushing the limits of precision.
Bismillah ar-Rahman ar-Rahim. Thank you very much, sir, for inviting. Um, so I'll be presenting a simple case. He is the boy. He was 18 years old, and coincidentally, he was working in our hospital in the medical store. And he has actually lived his life with this mess over it. So this was kind of a dermoid, we normally see it. We can clearly see that his pupil is not right. So just a portion of the pupil is visible over here. So we expected him to have not to have very good vision, which he did. So the vision was only counting finger, probably some dense amblyopia from this dermoid as well expected. But for last couple of years, he was experiencing a change, and that was that when he would look down, this mass would pop out from his eye. So this was a fresh change for last 2 years, which was concerned about. And I mean, considering his age, his main concern was cosmesis and not the vision. I deliberately took history of trauma, but he denied any ocular surgery or trauma because of that second swelling. Because I was expecting that to be kind of a retention cyst. So visual acuity, counting finger, we have seen that there was a nodular reddish swelling on the superior limbus with some hair follicles on it as well. And interestingly, that boy was actually in a habit of plucking those hair follicles from that swelling himself. He was quite expert in that. And the other swelling was a bit bigger one. So when he would look down, we would see almost 2 to 3 centimeters of swelling popping out from his lids from superior fornix, and that was for last 2 years only. These are two swellings. So we went for a CT scan because we were concerned that, especially the superior swelling, and that may have some deeper roots. So they said that he has got a limbal dermoid and a well-defined opacity, as we could see clinically. Um, Here we can see that. So what could it be? Obviously, it was a dermoid, and the superior swelling was, kind of an inclusion cyst, which we assumed. But other differentials like myxoma, dermolipoma, even lymphoma, some kinds of lymphoma, they present in early age group as well, or orbital fat prolapse, they were considered. But on merit, they were kind of excluded from the differentials, and these two were main differentials. So we planned a staged surgery. So in the first surgery, we excised the superior cyst, and then the second, we excised this dermoid. So here is a little video of the surgery. So this is the swelling. So we can see quite large swelling, almost 3 centimeters in this direction. And this was the post-op result. So from superior fornix, that swelling is gone. So after a gap of few weeks, we turned to the second surgery, and the limbal dermoid was removed. So as we all have done these surgeries, limbal dermoids, they need a careful surgery because they penetrate deep and you don't actually follow them. So be careful in your shaving of this lesion. If you go deeper, you may damage deeper structures. And this was removed. And after that, what we did was, because his main concern was cosmesis, so we did a very careful sectoral tattooing of that area. Now we need to be careful because if a gush of that tattooing fluid goes here, the pupillary area is very near. So just bit by bit, we were able to achieve this, and that was, quite satisfactory. Now, covering this raw area with a piece of amniotic membrane. There is the amniotic membrane. Now, we were concerned about histopathology, and especially about this lesion, because we were sure about this as a dermoid, and we suspected inclusion cyst, but the histopathology was surprising. So I had a personal discussion with the histopathologist, and one thing he agreed, and one thing he didn't. So this is histopathology report of the one labeled as dermoid. So he convinced me that this is a dermoid. This is not an inclusion cyst. And the proof he gave me was this hair follicle, clearly visible. And few sebaceous cysts are also visible. So if it would have been an inclusion cyst, it would have been only the conjunctiva. So these structures, they prove that it was kind of a dermoid with some altered anatomy in which clear fluid was visible. And sometimes we do see dermoids in this shape. And this is the second one. So here he agreed to me that again, this is a dermoid. This is not a hematoma, because we can see epithelium over here and we can see these sebaceous glands as well. So he agreed that the report is not probably correctly written, and this again is a dermoid. So we actually tackled two dermoids in the same eye. And the results were quite acceptable to the patient. He was really happy, although his vision was not likely to improve, which it didn't, and it remained at counting finger. But his main concern was cosmesis. We can see that his abduction has also improved. And all in all, that tattooing also worked well. So from a distance, nobody could judge that there was a white opacity over here. But otherwise, if you don't tattoo, then even if you remove this dermoid, a white opacity will still be there. So if patient's concern is cosmesis, it will remain a concern. So this was the case. I mean, we already know the difference between hematomas and choristomas and teratomas. Um, and dermoid cysts, they present everywhere in the eye, in the orbit. Superficial dermoids, they present early. Deeper dermoids, they may take a few years to appear on the surface. So the etiology is well known. These are types of the dermoids. This is epibulbar dermoid. So typical is that we will see hair follicles coming out from this opacity. So there are grades. If this is grade 1, just less than 5 millimeters of area will be covered, and grade 2, I mean quite a significant portion, but not whole of the cornea will be covered, and in grade 3, whole of the cornea will be covered by a dermoid. So they are the most difficult cases to deal with. There are associations of the dermoid, especially golden heart syndrome, but in this case, fortunately, he didn't have one. So sometimes you have dermolipoma. It was being discussed day before yesterday that their excision is also, it needs a careful surgery. You don't go very deep. So excise almost 80% of the lesion and leave almost 20% of it. And orbital dermoids, obviously, they also do present. So if it is here, I mean, we should be careful not to damage the lacrimal gland while removing. And if it is on medial side, we should be careful not to damage trochlea on the medial side. All right, for evaluation, if it is an orbital dermoid, go for a CT scan. If it is just surface, then CT scan is not needed. Sometimes deeper lesions may have some kind of bone erosion as well. So we need to differentiate them from malignant lesions. Differential diagnosis on the lateral side, lacrimal gland and all its lesions. On the medial side, congenital encephalocele, dacryocele, mucocele, all these should be considered. And the treatment may be anything from observation to a full-fledged surgery requiring an orbitotomy. So depending on the lesion, we can plan the surgery. Now, in literature, we see that people we utilized amniotic membrane, but people have utilized this smile lenticule to use as a cover over the area. So this is not a bad suggestion. We can always use it. And amniotic membrane is also reported. So these are few of the references I used, and this is the same lesion. Thank you very much.
Thank you very much for a wonderful talk, Dr. Mir. So next I'll talk briefly about differential tear dysfunction. Actually, it was prepared for residents. I see more seniors here, so just bear with me. And we've talked about ocular surface, we talked about tear function, and many times tear function is responsible for severe symptoms which we keep treating with different drops. All drops have got preservatives or preservative-free drops if available. We don't have a lot of preservative-free here. And we end up getting trapped in a vicious cycle where we can't get out, and the patient keep complaining. And these are I think, quite a high workload in our part of the world. No disclosures. So dysfunctional tear function is not only lacking quality or quantity, range from etiology of abnormalities from one layer to another with variable symptoms and signs. We have challenges here. We have challenges because there is lack of correlation between signs and symptoms. Sometimes patients come with lots of symptoms and we can't find much in the eye without doing in busy clinics, without doing investigations. There's lots of overlap, complex etiology, pathophysiology is sometimes poorly understood, historically limited range of diagnostic tests. FDA-approved treatment options also limited, and potential progressive nature of the condition. So patient keep on complaining, and when a patient comes, I don't know whether you've noticed that they come with a major problem like can't see, they have cataract, you remove cataract, and then they come and keep coming back and saying, well, something is not right. I've got itching, I've got irritation. Maybe they have this itching irritation before, but it was covered by their major problem of not seeing, and now they can see well, so they actually concentrate on the smaller little things. And this is like annoying for them, but annoying for the physician as well. And we want them to be better, but difficult. Some people have sort of this complaining attitude. Poor compliance for follow-ups. When they feel better, they just disappear and they stop their treatment. One of my patients who was told to just observe few restrictions after cataract surgery, phacoemulsification, 3 days. Just don't do this. Otherwise, just carry on. They actually stopped the treatment after 3 days. They said, oh, you said it 3 days. So I stopped the treatment. Fortunately, nothing happened. But this is how the understanding goes. So I have to be very careful explaining to the patients. I've got everything written on paper. It's all printed and it's all marked, and we hand it over to them. And hope for the best. Another problem is that there are very sort of interlinked cases. Well, one merged into the other. The tear function, one condition like blepharitis coming with aqueous deficiency and so on. So the symptoms and signs are different, and that's why we get confused how to treat it. Differential diagnosis can be aqueous deficiency, blepharitis, goblet cell deficiency, and exposure related. And I think exposure related, we are seeing quite a lot in this. We can do various diagnostics. There's some I agree and some I don't agree. I simply do tear film breakup time after doing the visual acuity, and I think it's a very quick way of assessing. If you have osmolarity check, you can check the osmolarity. Schirmer's test, generally I'm not very happy with it, but one way or other, whether you do it without or with, you interfere with the sort of anterior surface by putting the Schirmer strips in, and if you do it under local anesthesia or topical anesthesia, again you interfere. That anesthesia is also an irritant, so the results are not the same. As you said, if you have a tear function analyzer, a dry eye analyzer, you can judge, and they will give you quite a lot of information. So the treatment options are according to the condition, according to the deficiency, and so we just can't. Someone with blepharitis would have meibomian gland dysfunction. We can't just keep on giving them drops which are not actually going to help blepharitis. So we have to address the basic problem. So in all types of deficiencies, you can see that we have topical drops, yes, but this part of treatment will be different. We give nutritional supplements, we give anti-inflammatories like cyclosporine. I use cyclosporine quite a lot. I'm not a great fan of long-term steroids or similar medicine. In blepharitis, you always give lid hygiene and scrubs as well as nutritional supplements. Sometimes azithromycin and erythromycin helps, or tetracycline. With goblet cells, we give vitamin A ointment, etc. And exposure, you change the lifestyle. Exposure, where the exposure is happening, why it's happening. Is it the anatomical problem, or a patient is using the screen a lot, and treat them accordingly. Second line approach, we can give some medicine which increases the secretions, topical hormone treatment, insulin drops, and sort of dihydrotestosterone medicine can help. Autologous serum, another drug which I use quite a lot, and patients do feel a lot better with them. Sometimes the help is with the bandage contact lens. One of my younger patients who have very lucky to have not unlucky to have Steven Johnson syndrome, but very lucky to have a very partial one. He still comes with a tear dysfunction and is very comfortable when I put bandage contact lenses, but they do have their own risks. When you have blepharitis, doxycycline, course of doxycyclines, they help as well, along with acetylcysteine drops of various strengths. Goblet cells and exposure, you change lifestyle, scleral lenses help. What is the third line treatment? You go on to punctal plugs and occlusion, amniotic membranes. If they are filamentary keratopathy, you can remove them, you can do mucolytic agents and so on, and do eyelid surgery in certain cases where there is exposure. Drops we use quite a lot, and as I said, traditionally we don't have, and now we're getting, but still very deficient in preservative-free drops. And we all know what preservatives can do, especially back. Very good preservatives, very helps in a lot, but a long-term treatment, frequent treatment of drops, especially in glaucoma and lubrication, preservative-free drops are much helpful rather than preserved drops. Drops can vary with their constitution, and everything works in various different ways, but you can see that most drops will work intermittently, but some more on the lipid layer, more on the aqueous layer, and mucin deficiency. So we choose the right drops after diagnosing. They are viscosity enhancing agents, and they not only increase the thickness of the tear film, but also helps in retention of those drops, retaining it for a longer period of time. And you can see the list of them available. I'm not going to detail of that. Osmoprotection, some damage happening with the preservatives or otherwise, a dry eye, that the cells are dying, and that osmoprotection agents will help to negate that. Oily agents are very important, and it was wonderful to see. Once I was traveling in Egypt and I saw there was an excursion, and they showed us that a long time ago people used to preserve water in large containers because they used to have a shortage of water. And that reminds me of Karachi, because we still have shortage of water in this day and age. So I asked them, well, if they preserve it in these containers, the containers are open, doesn't it evaporate? And the answer was what we have in our eyes. They used to put a layer of oil on top, so it won't evaporate. And nature has provided us with that layer of a lipid layer on the surface, which prevents evaporation. Wonderful to hear that. Antioxidants, lots of injuries due to oxidative stress, and antioxidants will relieve that. Various type of drops. I'm not going into the names, available in different parts of the world. And you can see a small little area of meibomian gland blockage to a large area of blockage, 1 or 2. And this needs a different treatment than this and this. So diagnose your properly. When they have filamentary keratopathy, you add acetylcysteine or mucolytic agents. Look at these punctate stuff. Punctate staining can also be due to the excessive use of salt. So over treatment, when patient comes with keratitis or infections, we start treating them, and then we have a fear that if we withdraw treatment, it will recur. We have lots of nausea, so keep on giving the drops. And I think toxic keratopathy results in after a while causing the pain in the patient more than the infection itself. Do a meibography if you can. I can see loss of meibomian glands from grade 1 to grade 4. Treat them accordingly. Tear film breakup time, as I said, is a wonderful test, and for the residents learning, do it simply on your slit lamp. Refractive surgery is one where I am very careful with the tear function, and I always have epithelial mapping. Nowadays, people are using lots of gadgets and screens, so that eyes do get dry, the tear function does get dysfunctional, and do your epithelial mapping. And sometime on that basis, I refused to do a LASIK or femto in there, and I said, well, treat your tear function and come back to me later on, and then we'll do it. And post-operatively also, on a very small and low percentage of cyclosporine, I put them for a longer period of time. So the conclusion is that tear function is not it's very common, and it's very complex, and it's not easy to treat. It can lead to blurred vision, and patient comes and say, still have blurred vision. Patient comes and say, oh, femto is fantastic, I can see, but still I get blurred vision. So make sure that what is their environment they're working in, making sure that what is their, are they hydrating themselves properly? Are they drinking enough water? Are their eating habits are normal? Are they following 20-20-20 rule when they're using a screen? So change their environment, increase, help them in their journal health, hydrate themselves, encourage them, reassure them, and always listen to them. This is important. We do get in very busy clinics, we get agitated, and then we say, well, everything is okay, go. And this is not they deserve. They deserve a little better than that. So keep yourself hydrated, keep your eyes moist, and that will help you have a good, clear vision. Thank you very much. I'll call Alvin is the next speaker. Alvin is going to talk. He'll tell you himself.
Good morning, everyone. Thank you for being here on the last day. I'm from Hong Kong, from the Chinese University of Hong Kong. No conflict of interest to declare. It's my first time in Pakistan, and I look forward to doing some sightseeing later on before my flight tonight. I'm very honored and humbled to be here amongst esteemed clinicians and scientists. I've learned a lot, and I look forward to learning more from you. So this is just a situation of bilateral Pseudomonas conjunctivitis ending up leading to a bilateral limbal stem cell deficiency. This is jumping. I'm sure you've seen a lot of publications on how to manage limbal stem cell deficiency, and there are many, many different algorithms, but this is fairly general and fairly applicable. So for partial and total management is totally different. And obviously the difficult cases would be the bilateral cases. And you know, the area of limbal stem cell deficiency is an instruction course on its own. So today I'm just going to focus on one small niche area on SLET. So these are the surgical options as per the previous algorithm, what we can do in limbal stem cell deficiency situations. We can do autologous surgery or allogenic surgery, whether it's cadaveric or living, related or unrelated. The source of limbal stem cell can be simple, as per SLET, or cultivated, which costs a lot of money, and we don't have that in Hong Kong. And I tried to talk to my Japanese colleagues, but they don't export that technology. I can't send my material to them for surgery, so I'm stuck with no cultured limbal stem cell transplant in Hong Kong. It can be autologous or allogenic, as I said, allogenic SLET or alloclet. Conjunctival limbal autograft, as per my pterygium talk on Friday, is basically just including part of the limbus, and there are many different types, including the KLAL, etc. And then, last but not least, as I said, cultivated comet from Japanese groups, oral mucosa epithelium transplantation. So this is just a nice diagram to show you the basic steps of SLET surgery. You need a little bit of donor from a little bit of limbus from the donor eye, and then in the deceased eye, you need to remove the fibrovascular pannus. After you do a peritomy and clearance of the anterior surface, you place an amniotic membrane on top of that. Original design from Sangwon was 8 to 10 limbal explants. You can divide more if you need to. There's more modifications since then. And then you transplant the limbal autografts onto the AMT. So this is just a very neat diagram to show you the anatomy, just schematic diagram. After your peritomy, you put a bit of glue, amniotic membrane, and then you put more glue. You stick on the SLET, and then you put a contact lens to protect it afterwards. So these are just some videos from Dr. Basu. And on the top left is basically a standard procedure of harvesting your limbus. On the top right is basically you doing peritomy, clearing your scar tissue, etc. Bottom left is when you trim off the limbo tissue, the sliver of limbo tissue that you need. And then bottom right is obviously cutting that sliver of limbo tissue into different pieces, 8 or 10 or 12, up to you, as needed. So, what is success in SLED surgery? Basically, as per all limbo stem cell deficiency, we can get a stable epithelialized avascular cornea, then is success. And then failure is obviously the opposite, when there's occurrence of conjunctivization and loss of anything that's on the left. This is being automatic. Okay. Why is SLED? When SLED first came out, I had my doubts because I thought, why should it work? Is you're taking such a small sliver of tissue covering such a large area, and the limbus is supposed not to regenerate. So this is the reason. It's mathematical, basically. So for CLAU or KLAL, basically you take a large graft, 6 clock hours at least from the donor, and your total circumference exposed for the limbus is just 22 millimeters. Whereas for SLED, you only need to harvest 1 clock hour from the limbus. And then when you cut into small pieces, the total circumference exposed is 27 millimeters. So it's just mathematically more. And these are just some studies looking at the results of comparison of outcomes between SLED and the various other procedures for limbo stem cell deficiency surgery. And you can say SLED actually comes out quite well. So when you look about success of limbo stem cell deficiency, these are the considerations that you need to think about for long-term stability. I had a horrible patient, bilateral alkaline surgery, who went to the States and had some really heroic surgery done, but that didn't last. So we have to think about long-term success. So in terms of all these criteria, SLED actually is a very, very good option. Some may be as good as others, some at least as good as others. So tissue size, you don't need that much. So safety is safe to the donor eye. Epithelial lies is nicely. Success, similar rates. Visual outcomes, similar rates. And obviously it's affordable because you don't need expensive lab such as Comet or CLED. And then it's repeatable because you need only a small sliver of tissue from the donor, even you want to do allo or from another donor. So in terms of immunosuppression, sometimes my patients, they don't want to go for heroic surgery because when I tell them you need to go on long-term immunosuppression, they are not keen. So if you talk about Holland, Cincinnati protocol for limbo stem cell deficiency is actually very, very heavy. And you need to take it over long term in your whole life. That's a lot of medicine. And, some patients are not willing for that because basically you're just dealing with the eye rather than kidney failure or whatever, that you need such strong medications. There are different protocols for the SLED. You can use IV or the oral regime. We prefer the oral regime because it's actually more convenient for the patient and you need less admissions for IV, etc. What are the contraindications to allo SLED? Well, obviously a dry ocular surface. When it's totally keratinized, when there's, it's not really suitable for, when the surface is so dry, it's not suitable for SLED, it's not going to be successful. So Sherman's test less than 10 with topical anesthetic, you should be wary as well. And the other ones are probably a bit more relative contraindications because the first one, if you do it with a dry eye, poor surface, it's not going to do well. So this is the journey of our department. So in 2017, I sent my fellow with the ACS Stanton grant to Veranda, my good friend in the ACS Council. And then my fellow also went to the SLED workshop in 2018. And then we started our first surgery back in 2018. This is going automatic. Anyway, and then we move on to autostat, allostat, and then we've been doing that ever since. So in terms of healing, it heals differently to traditional superior and inferior limbo grafts because basically the limbo transplant is scattered all over the surface. So it heals from those little slivers of tissue and spreading outwards, healing. So you get overall healing rather than superior, the typical way from up and down. So this is just a healing picture. And these are just some OCT scans showing exactly what's going on. The stroma, the transplant tissue, as you can see by the orange thing, and then on top of the amniotic membrane and a BCL. So with time, epithelial is going to grow over the denuded area. As you can see, the green arrow, and part of it is still not covered, and it's just bare AMG on the central cornea. And then with time, probably by about day 8, depends on how many tissues you have, and its surface is pretty much healed. And you can see the transplanted epithelium growing over the denuded area on top of the amniotic membrane. And this is just a longer term, day 11. And then 3 months, 2 years. You can see the blob of tissue actually flattens out. So these are just some clinical photos showing you the outcome of from hand movement to 5-200, 20-200, 20-40, etc. So when you have no options, especially bilateral cases, and if we're not doing OKP, that sort of thing, this is something that you can think about. So the take-home message, careful case selection. The indication, if it's total limbal stem cell deficiency, poor prognostic factors such as very dry eyes, you should always do auto transplant before allo transplant because of the immune situation. It has to be meticulous surgery, so proper training of how much tissue you take and how you manage the tissue, handling in limbal tissue, amniotic membrane, and fibrin glue. And I think the last one cannot be neglected. It's the attentive post-operative care. You have to monitor epithelialization rate. The clinical assisted maybe with imaging as well. Adjuvant therapies, BCL plugs, and all of the previous strategies taught by the previous speaker. And then systemic immunosuppression. You must be able to manage that with the benefits and risks. So thank you. And I want to thank the Pakistan Ophthalmology Society for this honor, and my team back home, especially Dr. Gum, the big guy, who's been helping me a lot of work. And if you have time, please come to Hong Kong and join us for the Asia Cornea Society next December. Thank you. That's a very good question. I think you can try after wean it off according to the protocol after a year or 2, and then you see how they get on. If you see rejection, if they failure, then you might need to put them on something again. I don't think because basically I don't think there's large enough studies to do like hard science. There's a lot of art. It's just like it's almost like corneal graft rejection. There's a lot of art in it. So I'll talk to the patients how keen they are on immunosuppression. Systemic. If they are not, I might put them on topical tacrolimus long term. It depends on how bad the eyes are, how serious the condition, and what the patient, you need to talk to the patient because these are strong drugs, as I've said. It doesn't seem to. You mean the tissue flip end up down? No, it doesn't seem to because they'll be growing out of it anyway. As long as it's on top of the amniotic membrane, somehow, I guess nature will take care of itself. Just like if you do LASIK, the cornea will remodel after time. There's a lot of plasticity and thank God, in our human nature. I think it doesn't really matter. And sometimes you do get mixed up because they are such small sliver of tissues and the way you handle, you glue it on. I'm sure some of mine is flipped anyway, so.
Such a small pieces, they slip into and it comes back and
That's why you need to be very careful on table to make sure it's stable before you put the BCL on and take everything off. On Friday, someone talked to me and mentioned they can't afford sutures and pterygium, and they asked me if it's okay to use autologous glue. I've never tried autologous glue for sled. I think you need proper fibrin glue because if it's stuck, as you say, it would be lost and it would be wasted. Okay, thank you.
Thank you very much. Wonderful talk. Then the next speaker is Dr. Rita, and she's going to tell us about some epidemiology in Kathmandu. Thank you.
Thank you, Tanvir. Good morning, everybody, and I thank you so much, the Pakistan Ophthalmological Society, for giving me this opportunity. My talk is nothing to do with cornea, nothing to do with anterior segment. It is a study we did in Kathmandu. So this is an epidemiological study of ocular disease in Kathmandu district of Nepal. Yes, this is the investigation. Why did we decide to do this study was almost all of our population-based studies were done in the rural part of the country, and there was a lack of evidence, lack of population-based studies in urban part of the country to inform the policy and planning of eye care services. And we thought that the rapid urbanization and lifestyle changes in Kathmandu must have resulted in increased NCDs, which has an effect on an eye health. And the participants in this study was 4,990, which is 92% of the calculated sample size. So this is the training of different team. The main objective of this study was to assess the epidemiology of ocular diseases among adults aged 40 years and older residing in Kathmandu district for over 6 months. The male-female ratio is 63% females and 37% males. The mean age was 59 years. 71% of those taking part in the study were literates. We administered a few questions to the participants, and in the self-reported 62% of the participants, which were 40 years and older, had some kind of systemic disease, and mainly diabetes and hypertension. There were almost 21% had diabetes, and 37% had hypertension. And the subjects which were said that we don't have anything to do with the diseases, but 9% of them had hypertension, and 26.6% had diabetes. So there were lots and lots of people in the community which were not diagnosed with those hypertension and diabetes, which had both the disease has got a lot to do with eye health. In the hypertension and diabetic retinopathy, the patients who had diagnosed for the first time with hypertension had just 0.5% of them had hypertensive retinopathy, but 1.4% of those with known cases of hypertension have had hypertensive retinopathy. And as far as the diabetic retinopathy is concerned, only 1.6% of those who had first-time diagnosed diabetes had diabetic retinopathy, but 14.6% of those with non-diabetes mellitus had diabetic retinopathy, which was slightly lower than the national average of the country. We did the BMI status of those participants as well, and we always thought that Nepalese are not that much big. We are doing quite okay with as far as the weight is concerned, but surprisingly enough, 44% of the patients were overweight, and almost 24% of the subjects were obese. Although I have to tell you that the 81% of those who had obesity were class 1 obesity. But if the government doesn't bring any policy, or if we do not change our habits, we might go into class 2, class 3 obesity, and again this will bring to the increase of the NCDs. In the high-risk behavior, we asked the patients about their smoking habit and alcohol consumption habit, which is, I suppose it is reported, and 15% said that they are current smokers, and 30% said that they are current drinkers. So these all put together, the chances of increase in the NCD is higher, and we do have lots of things to do, especially the retinal surgeons will have lots to do in the future. We went to the eyes now, and because those subjects were 40 years and older, 90.5% and presbyopia not included, 90.5% of the patients had good vision, but 9% had visual impairment, and 0.5% were blind. And again, the prevalence of blindness in this population, in comparison to the national average, it is lower. Maybe because it is Kathmandu district, and most of the big hospitals and the accessibility to the care is more in this place. But if we look at the second line, the best corrected distant visual acuity, then visually impaired patients or subjects went from 9% to 1.3%, which means that we have to include refractive error in each and every screening or in each and every program, so that people will get good glasses and the visual impairment prevalence will go down, which is not very difficult to do. The principal causes of blindness in Kathmandu also came out to be cataract. Again, 41% or 42% of the patients were blind due to cataract, which is again less than the national average. And the main cause of visual impairment is uncorrected refractive error. We asked them about whether they were aware of the cataract, glaucoma, and diabetic retinopathy. And in the cataract, we were doing quite all right. 76% of the patient knew that they are aware of the cataract, and they said that they know that after the surgery they can have good vision. But as far as the glaucoma and diabetic retinopathy are concerned, not many people are aware of those conditions. And because this study, we wanted to tell the government that what should we be doing, what the government should put policy on. So we asked them about the sources of information. And about the cataract, they said that this is just the health professionals were from where they got the information. But for the glaucoma and diabetic retinopathy, it is just the relatives and friends were the sources of information. So the government has to take which way they have to go to increase the awareness of those diseases in the population. In the utilization of the services, 91% of the people who had some kind of eye problem when sought for the consultation, and 71% of those went to the eye hospital, which is good that they can take the advantage of the eye hospitals to go for the eye consultation. And for the barriers, maybe the need of very good vision depends on what they do. So most of the time, the oldies didn't feel that they need very vision better than what they have. And time constraints, no companion to go to the hospitals for the surgery or for the treatment. And 18% of them sought alternative medicine for their visual discomfort. And quite big chunk of the subjects had financial constraints to get the eye care services. Because we do have the eye bank, and we always try to mix all those everything together. So we asked them about the awareness of the eye donation, and although 56% of the patients of the subjects were aware of the possibility of donating the eyes, but in that cohort, only 18% of those cohorts were willing to donate. And then we went back, and we had 0.5% of the people were blind, and in the number wise it was 24, and 2 of the 24 did not go to any of the eye hospitals or clinics or anywhere to seek advice about their blindness. And we went back again and looked at the data that both the subjects were females, and they were 80 years, more than 80 years old. So 1 in 10 blind people did not seek any eye consultation, even in Kathmandu. So as what we found out that as age increases, the odds of having vision impairment and blindness also increase significantly. Women were more at risk of blindness in comparison to men. Illiterate participants had significantly higher odds of having vision impairment and blindness comparison to literate participants. As hypertension level increased, the chance of visual impairment and blindness also increased. Compared with non-diabetic people, again, the diabetics had more chances of having VI and blindness, and in comparison to the non-smokers, smokers had the higher chance of being blind. So in conclusion, the prevalence of blindness in Kathmandu was 0.5%, and the main cause of blindness remains cataract. The prevalence of visual impairment was 9%, which was corrected to 1.3% if we given just the good pair of glasses. And the blindness was associated with increased age, female gender, illiteracy, systemic diseases, smoking, and alcohol consumption. 62% of the prevalence of diseases reflecting rise in NCD-related condition, for example, hypertension and diabetes, which reflects lifestyle and demographic change. 9% of the participants were newly diagnosed with hypertension, and 27% were found to have diabetes mellitus newly. The barriers of utilization, although they don't feel that they need surgery or any medication, time constraints, lack of companion, and cost of the treatment was the limitations for them to take up the services. In the eye donation, willingness to donate remained low despite awareness reflecting continued misconceptions and limited community level education. So this is the study we did in Kathmandu. It's a big study. I just gave you a very snapshot of this study of the results, and we are coming up with the report and advising the government that where we are and where should we be going in the future. Thank you so much.
Thank you. Wonderful talk. One of my teacher, Dr. Shiraz Daya, is a part of Orbis, and they have this aeroplane-based traveling hospital where they go different places and not only collect data but also provide clinical services. So that's wonderful. Dr. Shehzad Mir is going to talk next on role of PKP and corneal edema, something.
Thank you very much. It's certainly a true honor for me to be participating in the Ophthalmological Society of Pakistan's meeting, and congratulations to such a successful symposium. So my task here is to look at seeing if there is a role for full thickness or penetrating keratoplasty in patients with corneal edema and over endothelial keratoplasty. I don't have any financial interest in the materials that I'm discussing. Certainly, full thickness corneal transplants have been the mainstay of how to manage corneal disease over the last 120 years, ever since the first successful procedure was performed in Hungary by Edward Zerm. But we know that in the last 15 to 20 years, there's been a growing ability to perform endothelial keratoplasty with significant advantages with DSEC for management of endothelial disease, and of course now even with DMEC with advantages even over DSEC and success for management of corneal endothelial disease. And we know from our data in the United States, at least through the Eye Bank Association America, that 2/3 of the grafts that we now perform are endothelial grafts. But 1/3 of them are full thickness grafts. And when we look at the international data, now this is tissue that's provided by the United States for corneal transplantation worldwide, the number is even higher. 63% of the corneas that are provided from the US are for full thickness grafts. When we look at the indications for corneal transplantation full thickness, in the US, endothelial disease still accounts for 35% of all full thickness grafts for being performed for endothelial disease. Now, the data is not as clear for international use. It only accounts for about 10%. But then again, if you look at the number down at the bottom, 72% of all the cases are unknown because the indication is not reported back to the eye bank where the tissue came from. And when we look at the number of grafts that are done for management of endothelial cell failure, of all the grafts, 22% are still full thickness grafts. So there's clearly a role for full thickness grafts in management of corneal endothelial disease, because that's how we're practicing even in the current state. So I'll go through a case here. This is a 24-year-old who presented with eye pain, sharp pain in the morning in the right eye, has a history of Peters anomaly, is aphakic, and the left eye was actually removed because of multiple procedures and failure with residual chronic ocular pain with no light perception vision. The eye that we're talking about here, the monocular patient, also has advanced glaucoma, again, has had multiple surgeries, including a trabeculectomy, a vitrectomy, a glaucoma drainage device. But the visual potential seems to be pretty good, was as good as 20/60, 20/70 with correction at least a year prior. Currently, the glaucoma is medically being managed. The vision at this point is hand motion. The intraocular pressure seems to be stable. The cornea is quite edematous. So what should we do here? A full thickness graft or endothelial keratoplasty? So a lot of you may say endothelial keratoplasty is the procedure of choice here, and it very well may be, but I think it is important to consider full thickness grafts in the setting as well. A full thickness graft, as many of you know, is a surgical technique that's much more familiar to us, where we are removing the diseased cornea and replacing it with many different types of suturing techniques, which can be quite successful in managing many of our patients. In fact, the largest set of data that we have for in a prospective trial for penetrating keratoplasty was in the cornea donor study, which was performed with 1,100 grafts in between 2000 and 2002. This included 105 surgeons, 43 eye banks, and this is all for endothelial disease. 62% of the patients were Fuchs, and the rest were either pseudophakic or aphakic. Now, of course, this was performed in an era when we were not performing endothelial keratoplasty, but it is a prospective real-world study of a large number of surgeons. The main goal of this study was to look at donor age, if that was a factor in recipient outcomes, looking at greater than 66 or less than 66 years of age for donors. And what did this study show us? At 5 years, there was an 86% success rate for full thickness grafts in endothelial disease. And a 10-year follow-up study, also in the same patient cohort, showed that there was a 71 to 77%, no significant difference between the two groups of success rate, again, even at 10 years. And of course, the primary goal of the study to show if age was a factor was not a factor in the study as well. Now, we know penetrating keratoplasty has lots of limitations, as we heard from earlier talks in this session alone, with respect to visual rehabilitation, the structural integrity of the globe being compromised, suture-related complications, and graft rejection. But we also know there are limitations with endothelial keratoplasty as well, including limitation in best-corrected vision, refractive errors, endothelial injury, and graft failure, especially in this case, talking about primary and long-term graft failure in complex eyes. DMEC similarly also has complications and is not the best procedure for all endothelial disease, in part because of the learning curve, but also because of the surgical technique as well. Now, what about outcomes for corneal transplantation besides the cornea donor study? The Australian Corneal Graft Registry published their data about 10 years ago, where they actually showed that penetrating keratoplasty in Australia had better outcomes than endothelial keratoplasty, and both Fuchs and pseudophakic bullous keratopathy. This study also looked at rejection rates, and they were equivalent between endothelial keratoplasty and full thickness transplants. Here's another case, 75-year-old with gradually worsening vision in the left eye with a history of advanced glaucoma, trabeculectomy, glaucoma drainage device again, post-cataract surgery, has vitreomacular traction. This patient had vision decreased to 2300, corneal thickness was high, exam was consistent with bullous keratopathy. The patient underwent a DMEC procedure. The patient came back 1 year later and had significantly decreased vision, although it had improved early, and 2 years later had poor vision in that eye, in part because the patient did not follow up and rejected and failed their graft. So when we have to repeat surgery here, should we consider penetrating or endothelial keratoplasty? You could certainly argue to repeat a DMEC or DSEC procedure in this case, but you can consider full thickness grafts. Why? Because we know that endothelial keratoplasty in eyes with prior glaucoma does not have good success. Here's a series comparing Fuchs corneal dystrophy patient who underwent endothelial keratoplasty. When they did not have glaucoma, the success rate in this series at 4 years was 88%. But if these patients, the ones who had glaucoma, the success rate dropped to 27% in 4 years alone. What if we separate out in patients who had a glaucoma drainage device or no glaucoma drainage device when they had glaucoma? It even further separates out that the success rate of patients with glaucoma drainage device at 4 years was 17%, and those who did not was significantly decreased, but not as bad. How about in patients who had trabeculectomies? There are also differences and significantly worse visual outcomes because of failure of grafts in patients who have a DSEC combined with a trabeculectomy as compared to a full thickness graft combined with trabeculectomy. And this is a study looking at comparisons between glaucoma drainage devices and trabeculectomy, and there's a graded increase. Patients who had no glaucoma had the best graft survival, but if you add in a surgical treatment of glaucoma, especially glaucoma drainage devices, you can see from going from the blue to the green how much the graft success decreases over that 4 to 5 year time period. Here's a study looking at outcomes comparing patients with graft survival when glaucoma surgery is performed after the transplant. So that is that the glaucoma drainage device is placed not before surgery, but after the corneal transplant. And success rate is significantly reduced in both groups, full thickness grafts and endothelial keratoplasty, but seems to be worse with endothelial keratoplasty as compared to full thickness grafts. There's a study looking at DMAC grafts after failed PK in eyes with glaucoma drainage device, also showing similar results when we follow them up to 3 years out. When there's no prior trab or tube, they have pretty good success rates. But if there's a prior trab or tube, the success rate dramatically decreases. So when we look at endothelial keratoplasty as challenges, there is clear data that glaucoma drainage devices and trabeculectomies both increase risk for graft failure, whether it's a consequence of endothelial injury, graft dislocation or entrapment during the procedure, and you can consider full thickness grafts in these cases. Certainly in patients who have aniridia or aphakia, there may be even more indications to consider performing a full thickness grafts because these patients, we have a hard time getting the graft to attach well. And there's a significantly higher rate of posterior dislocation of the graft. One of the options that we have in this case is to suture the DSEC graft, for example, and that can certainly allow for attachment of the donor tissue, but you can, again, consider full thickness grafts in these kinds of cases. What about patients with severe corneal edema where the corneal stroma is altered? That is, that there is more scarring that's to be predicted with performing an endothelial graft alone. Again, you can consider doing a full thickness graft in these kinds of cases as well. There's a nice series that was published recently looking at regrafting after PKP. So that is, if we have a patient who's already had a PKP, and then you go in and consider repeating surgery with either PKP or endothelial graft. And when we look at 5-year graft survival alone, it is fairly equivalent. That is, EK grafts don't necessarily do any better than full thickness grafts in the setting. So in summary, penetrating keratoplasty remains an essential surgical technique to manage corneal disease. Penetrating keratoplasty can be utilized in treatments of endothelial disease, even in the era of endothelial keratoplasty. Thank you.
Thank you very much. Next speaker is Mohammed Amar, and is going to talk about pterygium surgery. I have recently, what I call, we talk about penetrating keratoplasty going out of sort of fashion, but there's still some indication. I recently saw I call it a triple graft. The patient has had a DMAC, and there was a failure, and followed by another DMAC, and then ended up having third surgery with penetrating keratoplasty. Unfortunately, that failed as well. So things can happen, and I think, as I always say, make sure that you give patient a realistic hope and counsel them well. That counseling is something which will help you post-operatively as well. And write it down for residents or juniors. Please write it down. If it's not written, it never happened. So write down everything, whatever you explain to the patient. The written notes are your savior in many occasions. Thank you.
Okay, good morning. Today I will just explain a little bit about my procedure, which I'm doing since around 14 years. Pterygium excision with sutureless and glueless grafting. And my surgery, my journey into the pterygium surgery started my journey in ophthalmology at Services Hospital, Lahore, from 1996 to 97. Then I joined the LRBTI Hospital, Lahore, for my residency, where I worked up till 2005, and then I joined in Saudi Arabia, Armed Forces Hospital, and where I am working up till now. So initially I started with the bare sclera and primary closure techniques. I was introduced to sutured autografting in LRBT, and then I continued it until I started to do the sutureless and glueless grafting. Dr. Young already explained about the epidemiology and pathology, so I will just go into the surgery. So after drying the surface, mark the limbus, and use one scissor to split the pterygium at limbus, and then using a mini 64 or any round feather 15, just peel the pterygium head from nasal to the temporal side, finding the right plane of pterygium. So it helps to smoothen the cornea later on. Then dissect the pterygium body from the conjunctiva. Using the Westcott scissor, and I cut the pterygium body, taking care of the muscles and other tissues. Clean the bed. We have to remove the adherent tissue. After cleaning, measure the recipient area. I have found that less than 6 millimeter on the limbus is usually there will be recurrence if you use a 6 millimeter, less than 6 millimeter graft. This step is very important to mark the harvesting area, harvesting the tissue, and inflate it. So the arrow will guide us later on when we implant the pterygium. Using the Vanna scissor, I just try to get the thinnest possible graft. Using the non-tooth forceps, giving a contraction towards the 6 o'clock, and using the Vanna scissor to make a countertraction. I get to do the sharp and blunt dissection and creating a very thin graft. As you can see, the vessels are giving me the landmark to get this as thin as possible, and then flush cut it from the limbus to include the stem cells. And it's very sticky, and you see what happened. I almost lost my graft, but it was on the field, and now it's simple. The importance of the arrow will be shown that once, yeah. So you spread it and you flip it with the 2 non-tooth forceps, and the arrow will guide us where it was and how it has to be implanted limbus to limbus. Now create a fresh film of blood here on the bed and just slide the graft and tuck it under the conjunctiva. Using a dry cotton tip applicator, just press gently over it and we need 6 to 8 minutes to just stay there and after that check again for adhesion and that's it. No eye drops are instilled or eye ointments, nothing is put in the eye at this time. Just carefully remove the speculum, check again and close the eye with strong adhesive tape, Steri-Strip or any strong adhesive. I am using Steri-Strips and we remove it next day in the morning. So key points are that we need a retrobulbar with long acting because we need akinesia for few hours. So I use bupivacaine and xylocaine, 3:1 ratio. So other thing is no infiltration in the tissue, the pterygium, because the grafting bed size is important. I don't want the large graft. And I have found after long experience that splitting the pterygium at the limbus gives a good plane to peel off this tissue on the cornea and gives a good smooth surface. And while dissecting the pterygium body, try not to excise the conjunctiva. It will enlarge the grafting area and the grafting graft tissue will need excessively large grafting tissue. So we need to keep it. So as you saw, I just split the head on the limbus and my size was 6 by 4.5 millimeter. So if I remove little bit more conjunctiva, you will get like 7 millimeter on the nasal side. So it's not a nice thing to have a big graft from the donor area. Of course, marking an arrow is very important. If you lose your graft or orientation, you must have in your putting it limbus to limbus. And also harvesting thinnest possible graft is important because it will stick nicely and it will not retract after surgery. Yes, for getting it stay sticky, we need also some fibrin. So we use fresh blood and the fibrin is enough on this blood to get stuck there. And it's also I think it's important that you stop blinking in the post-operative period for at least 24 hours. So, and it will help to stick the graft. Also pray at night because it's without sutures, your heart is always sinking. I don't know what will happen. So, and I use topical steroids plus antibiotics for 2 weeks, then followed by cyclosporin 0.05% for 2 months. So to decrease the recurrence. Now the disadvantages. Time consuming. Standard time is 45 minutes. I have tried to be faster, but no, it should be 45 minutes. It takes long time. And needs retrobulbar Of course, if there is no akinesia, I will suture the graft. I will not put it sutureless. And risk of this graft displacement and loss is there. And I have lost 2 grafts, one by our nurse who cleaned the eye very nicely next day. So the other grafts in which akinesia was not achieved. So from that, we learned that the dressing should be done by the doctor himself next day. Nobody should touch the eye until the surgeon will see the patient. And further procedure, that superior bulbar conjunctiva are compromised. Of course, you remove some tissue from the superior conjunctiva. So a patient will need trab in the future. We don't know what will happen. So although thin graft, there is healing there, but still. And learning curve is little bit, there is a learning curve for removing harvesting the graft. Advantages, of course, material cost is minimum. No fibrin, glue, no sutures, so it's very cheap procedure and consumable. But time is important for us also in high volume surgeons, so it takes time. And recurrence rate is less, and pain and irritation is extremely less as compared to suture graft. And the recovery is quick. Typically in a week, patient feels fine. So this is one of my patients, pre-op and after 1 week, and 3 weeks, and tonal area after 3 weeks. So, thank you very much.
Thank you, Amar. Have you had any next day subluxations or?
I had 2 mild displacements, 1 corner displacement, which was corrected on the slit lamp, and closed the eye for next 24 hours, and that's it. But yeah, it is possible, but in my population, it's not like that. I have young patients who don't use antiplatelets, anticoagulations. Of course, if there is disturbance with it might be a problem here. So yeah, we check at the end the graft if it's not sticky enough, so we can suture it at the end.
Thank you. And also, you mentioned about the donor side. I do this surgery routinely, not without sutures, but I do use 80. The donor side, actually, if you remove it very thin epithelium, it heals. I mean, within few days, you don't even feel that there's something was done. Don't disturb the tenon. That's the important thing. Do not disturb the tenon. Just remove the epithelium, and you can have future trabeculectomy. God forbid if it needs it. Thank you so much. Dr. Shahzadmi is going to talk next. Thank you.
Thank you very much. So I'm going to be covering limbal stem cell deficiency more broadly, and we've heard a lot already from Dr. Young, so my talk will overlap a little bit with what he covered as well. I don't have any financial disclosures related to this talk. I'll start with the case. This is a 19-year-old who presents to our clinic after being splashed with lye solution in the left eye a day prior. This patient already had been irrigated and managed acutely, but now at this point has very severe limitation in vision. The intraocular pressure is low, and you can see from the slit lamp evaluation, this is a monocular injury. The other eye was normal, but this eye is chemotic, is injected, although unfortunately, the worrisome is that there are multiple areas of blanching already within 24 hours at the limbus. There's diffuse corneal edema, shallowing of the anterior chamber, and even formation of a cataract already. And unfortunately, also there's decreased corneal sensation in this eye, so there's deeper nerve damage that has already occurred as well. So these are unfortunately consequences of the severe chemical burn injury, which can cause damage to the conjunctiva, all surface layers, and even deeper layers of the cornea, the limbal stem cells, ciliary body epithelium, and even the lens. And its long-term consequences over time turning into limbal stem cell deficiency with scarring, neovascularization, and unfortunately, poor visual prognosis. Limbal stem cell deficiency is defined as an ocular surface disease caused by a decrease in the corneal epithelial stem or progenitor cells, resulting in its characteristic presentation of conjunctivalization of the cornea. These patients typically have persistent or recurrent epithelial defects, neovascularization, ocular surface inflammation, and scarring. Causes of limbal stem cell deficiency can be divided into acquired and genetic. We saw an example of chemical injury, but certainly thermal radiation injuries, infections, inflammation such as Stevens-Johnson syndrome, graft-versus-host disease, mucous membrane pemphigoid, and at least in high-income countries, contact lens wear is certainly a significant cause of at least partial limbal stem cell deficiency with poor contact lens hygiene. And again, there are a number of genetic conditions that can lead to presentation, and iridia being the most common of them, at least in our patient population. It is helpful to understand limbal anatomy. The limbus is the transition zone between the sclera and the conjunctiva and cornea, and they are specialized cells which reside in the basal epithelium at the limbus in the palisades of Vogt. These are these crypts that are present at the limbus, which continually produce cells that become the epithelium. They inhibit corneal invasion of conjunctiva and vasculature, and that is an equally important function in addition to providing the surface cells. There are specific markers that can help us distinguish these cells from the surrounding epithelial and corneal cells. And it turns out in a number of studies that we need at least a minimum of 25 to 30% of our limbus. Now, we don't of healthy limbus, so we don't always know how healthy the rest of the limbus is. So we have to be more cautious, but you don't need all of your limbus to be able to reepithelialize your corneal surface after an injury. A lot of these patients are asymptomatic when they present, and this is especially true in common etiologies of stem cell deficiency or partial stem cell deficiency, such as contact lens use. They can have discomfort, irritation with foreign body sensation, redness, tearing, light sensitivity, and of course, decreased vision with progression of the stem cell deficiency. Clinical signs, like in the initial case presentation, can include corneal neovascularization and scarring, subepithelial fibrosis, pannus formation, the persistent epithelial defects, and often a Werr-like keratopathy is an earlier stage way to diagnose stem cell deficiency. So these clinical signs, these are montages of various severities of limbal stem cell deficiency, where you can see from a fluorescein staining pattern, the whirling pattern as it's located peripherally versus centrally, and with progression resulting in epithelial defects. And the second montage is looking at the clinical appearance as well as the staining, and using confocal microscopy to compare at that. As we have progression, we lose corneal nerves, and the epithelial cells become more irregular in appearance, and we lose the palisades of Vogt that are present in the limbus. The diagnosis is primarily clinical. Conjunctivalization of the corneal surface is the hallmark of limbal stem cell deficiency, so we're using slit lamp biomicroscopy to make that diagnosis. I already showed you some examples of corneal fluorescein staining, but there are tools that can really help us confirm the diagnosis, especially when there's any question and you're trying to make long-term decisions about how best to manage this patient, including impression cytology and biopsy, which both are trying to look for presence of goblet cells in the corneal epithelium in excessive amount, which are typically present in the conjunctiva and not the corneal epithelium. And there are specific biomarkers that can help us in terms of looking at the impression cytology or biopsy that help distinguish the corneal epithelium from conjunctival epithelium that is abnormally present. confocal microscopy can be a good tool in these cases as well, as long as the patient is able to cooperate and we're able to get good images which show a loss of the normal corneal epithelium structure, loss of the corneal innervation that's normally present subepithelially, and again, loss of those palisates of Vogt where the limbal stem cells are present. Anterior segment OCT can also show us some clinical features that are consistent with limbal stem cell deficiency, including the irregular thickness of the corneal epithelium. It may be thicker in some areas and thinner in other areas. There's significant subepithelial fibrosis that you can visualize, and again, presence of corneal neovascularization. You can look, none of these images show it, but you can look for the palisates of Vogt with corneal, with OCT as well, and at the limbus, but those are hard to identify, and there is partial loss of palisates of Vogt even with age, so it's harder to make that diagnosis. This is not a sensitive test for that. So when we're talking about management, optimization of the ocular surface, one of the first things we have to do is address any abnormalities of the eyelid or the conjunctiva, because often these patients have a whole host of eyelid abnormalities that are going to prevent any further intervention or management of these patients. So whether it's ectropia or entropia, trichiasis, lag, lid margin keratinization, shortening of the fornix, all of these things may need to be addressed first, and this can include a number of procedures that are listed here, and these patients may need to be immunosuppressed to control their ocular surface inflammation, especially if you're trying to manage it at the eyelid or deeper fornix level. We do have to, of course, control inflammation broadly and on the ocular surface. This usually includes use of topical steroids, but systemic steroids may be needed, amniotic membrane grafting, use of tacrolimus, and systemic immunomodulating therapy, again, plays a role in trying to minimize inflammation before we move on. Management of the tear film and treating the meibomian gland dysfunction, as you heard earlier today as well in this session, is important for in these cases, and perhaps more so than anything else, making sure that you're adequately lubricating the surface using topical oral tetracyclines, serum tears, tarsorrhaphy, and even minor salivary gland transplantation plays a role in these cases. Optimizing the ocular surface epithelium by avoiding preservatives, using serum tears, and scleral contact lenses can be a great tool in not only helping manage the surface, but also providing patients better visual acuity where they may not need any further treatment. When discussing surgical management of limbal stem cell deficiency, the two components that we have to look at are the staging of the limbal stem cell deficiency and the laterality. The staging here is primarily based on how much of the limbus is involved and how central the involvement of the consequences of limbal stem cell deficiency are present. So how much of the limbus is really based on if it's less than 50% or more than 50%. As I was mentioning earlier, you need about a third of your limbus, but a 50% cutoff is helpful in looking at the severity and if what can be compensated for by the relatively healthy limbal stem cells that are present. And centrality is defined by the central 5 millimeter zone to assess how severe that stem cell deficiency is already there. There are a whole host of surgical procedures that are potentially available. Dr. Young covered some of this, and I'll overlap a little bit with some of this as well. The distinguishing feature here again is going to be unilateral disease has its potential options for surgical treatment, as Dr. Young talked about, and bilateral disease has its own set. So unilateral disease, again, having differentiation in terms of what you can offer as compared to bilateral disease. As Dr. Young kind of showed us, a conjunctival limbal autograft or an allograft, just a very similar procedure, involves replacing 2 to 3 clock hours superiorly and inferiorly from the donor eye into the recipient eye after removing the corneal pannus and removing, really excising or resecting the conjunctiva back, so you give those limbal stem cells that you're transplanting the opportunity to grow over and without competing with the conjunctivalization. Here's a patient who had clearly had limbal stem cell deficiency with an irregular epithelium who underwent conjunctival autograft and then later required a corneal graft procedure for visual optimization. Conjunctival limbal epithelial transplantation, as defined by culturing and by biopsying and growing and expansion ex vivo, is not available at our center either. In the United States, there are a couple of centers that offer it. Mass Eye and Ear and UCLA have programs for this. Mass Eye and Ear has closed their clinical trial. UCLA still has an ongoing clinical trial. This was available in Europe about a decade ago, and from my understanding, it is not available anymore because of cost-related issues. It was about 95,000 euros when it was available about a decade ago, and in the U.S., the only two centers are only doing it in a clinical trial format, so we don't know what the cost is going to be. But unfortunately, very cost-prohibitive in terms of what we can offer in terms of the allograft or the autografts. So we heard a lot about the SLET procedure, and I'll show you my sort of version of it, but very similar in terms of what Dr. Young showed as well. So I have a video. So this, you can see, is the eye which has severe limbal stem cell deficiency with diffuse neovascularization and scarring, and the conjunctiva and the surrounding area is also significantly impacted with very thickened tenons that's present, and you really want to dissect down to the sclera as much as you can, 360 degrees, either excising tenons where you can, and at the very least, moving it back. So moving it back 3 to 4 millimeters from the limbus at least to allow some time for any stem cells you're putting on to grow back. That's fibrin glue, followed by placement of an amniotic membrane graft. This is a cryopreserved graft that's being placed. And I like to suture the edge of the conjunctiva down to, again, at least try to reduce how fast that conjunctiva is going to grow back over onto towards the limbus. This is the preparation of the donor eye, because this is only unilateral disease. I like to go down 350 microns because the palisades are thought to be about 250 microns in depth, a millimeter into the cornea and a millimeter back from the limbus, and then dissecting this into the 10 to 12 pieces. I agree, as the question was asked earlier, there is no real orientation. You can't really fully control how you put these pieces on in terms of orientation. And then you can either diffusely spread them or you can put them in the periphery. Either one of those options is reasonable. And then fibrin glue is applied to each piece to let it stick wherever you're placing them. And what you do after this can vary, and I've changed my technique depending on what the success of my last 3 cases has been. In this particular case, I actually placed a second layer of amniotic membrane on top with fibrin glue to give an opportunity for those stem cells to stick better and grow out before they fall off, accidentally at least. I have done the procedure with bandage lenses, but I've also had cases where the limbal stem cells, those pieces have gotten stuck to the contact lens, and then of course when you remove the contact lens they fall off. And I do think that doing a tarsorrhaphy is really helpful in these cases because it helps make sure that there's time for the eye to heal, and you are at least reducing the variable of the patient accidentally rubbing their eye, even when they're putting medications in. And these procedures can be very satisfying and improve patients' vision. Then you can potentially manage with either a scleral contact lens or go back and do a anterior lamellar or deep anterior lamellar or possibly even a full thickness graft to manage them. Now, allograft SLET is certainly a good option to consider. One of the things that we worked with our eye bank was to see if the eye bank can provide allograft SLET pieces rather than us doing it on our own. And at the very least, it led us to help study the limbus a little bit better. So this was a series of 12 eyes that were from donor eyes at the eye bank level that we looked at, and trying to see if the time period for storage impacts the success rate in these cases, as well as where we're getting them from. So it turns out that the stemness of these allograft cells actually goes down probably close to 0 by day 7. So at least in our small series. And so the placement optimally should occur by day 4, which by itself puts a challenge in place because it's hard to get donor tissue cleared to be able to prepare for allo-SLET within 4 days after the eye is available. We've also looked at seeing if we can cut keratolimbar allograft pieces similarly, but this is 2 to 3 millimeter wide pieces. This led us to help evaluate the palisades of vote, which is what you're seeing pigmented in this picture here, where they were present 200 to 250 microns deep. So again, that's the optimal depth that you want to look at when you're preparing your donor tissue. You don't need full thickness the tissue from the limbus from a donor, and thinner tissue may actually adhere better and minimize the amount of additional inflammatory tissue that you're placing. So at the eye bank level, this can be prepared by using a vacuum trephine centrally and then dissecting out to the limbus and then cutting the 2 to 3 clock hour pieces. But in this case, it's because it's an allograft, the eye bank can provide 360 degrees, so you can use all of it for your placement. So implications here are that the donor tissue has a lower success rate. You don't always have to do it centrally. You can certainly do it lateral tarsorrhaphy, and I think that depends on the patient, how much you know, how compliant they can be with what you're doing. In general, I find that central tarsorrhaphies are more effective for being a tarsorrhaphy, of course, as compared to lateral tarsorrhaphy. But I think you're asking the question in relationship to getting medications in the eye. In my experience, a central tarsorrhaphy does not preclude getting drops in very much. Most of the time, there's enough space that patients can get drops in. Donor limbal stem cells should be utilized within 4 days, again, based on our study, and corneal storage media that's formulated right now for management of routine corneal grafts may not be the ideal storage medium for these cells. And so with our eye bank, we're working on seeing what supplements could allow these stem cells to be better stored for a longer time period, which certainly would help in their shipping and utilization. And then keratolimbar allografts, of course, are, as you heard earlier from Dr. Young, are, of course, a procedure that we should consider when there's bilateral disease. This, of course, requires really transplanting 360-degree limbus, so it usually requires 2 cadaveric donors to be able to get the 360 degrees, and, of course, requires systemic immunosuppression for an extended time period, as we heard. This is a fairly typical regimen that can be used, but cyclosporin, of course, can be replaced with tacrolimus as well. But the mainstay long-term is mycophenolate, and that can work fairly well. It's relatively safe, but how long do you need to use it? I would agree that you have to titrate based on how the patient is doing, and you may have to keep them on for an extended time period, which then requires regular drug monitoring for drug levels, for toxicity, and making sure the patient is not overly immunocompromised. And of course, topical therapy is a critical portion of maintaining long-term as well. Living-related allografts may provide better success, but still require systemic immunosuppression. But the donor preparation, of course, is more similar to autograft. You want to limit how much limbal stem cells you remove from the donor eye, no more than 4 to 5 clock hours. For patients who are poor candidates or are not able to be managed with limbal stem cells, you can consider keratoprosthesis placement as well. The most common indications for Boston keratoprosthesis are patients who are poor candidates for either primary or secondary penetrating keratoplasty with failed grafts, chemical burns, and stem cell deficiency associated with aniridia, pemphigoid, and Stevens-Johnson syndrome, although pemphigoid and Stevens-Johnson syndrome don't do very well with keratoprostheses, especially with more advanced disease. You do want to try to make sure these patients have some degree of blinking and tear film to be able to maintain the ocular surface. And of course, no obvious posterior pathology is assessed by ultrasonography, no retinal detachments or advanced optic nerve cupping. The type 1 Boston keratoprosthesis, which is the most commonly used design, has a front plate of 5 millimeters, a stem of 3.35 millimeters, and a back plate, which varies in size depending on the size of the eye that you need. It can be a PMMA backplate or a titanium backplate, and it can be aphakic or pseudophakic, providing a visual field about 60 degrees. So here's a case of a 21-year-old with bilateral alkali injury with stem cell deficiency who initially underwent keratolimbar allografting with a living-related donor, went on the immunosuppressive regimen, had a penetrating keratoplasty, cataract surgery, with a remarkable result of 20/60, but unfortunately had an acute allograft rejection that was not recoverable, and the vision dropped to light perception vision. This patient also had significant glaucoma requiring glaucoma drainage device, and when that did not control things, required a diode laser CPC. And unfortunately, this young patient also was diagnosed with a hypernephroma requiring a nephrectomy, and therefore not being a good candidate for any further management with cyclosporin systemically. So here are the slit lamp photos. A patient had a bilateral vision of light perception. The ultrasonography fortunately showed no retinal detachment and underwent a Boston keratoprosthesis procedure. This procedure itself is very similar to just doing a full thickness graft, except for preparation for your Boston keratoprosthesis. The corneal tissue is trefined with an 8.5 to 9 millimeter trefine, and then the device is assembled. It comes, as you're seeing here, the front plate is put on adhesive tape just for allowing the assembly of the complex. The donor tissue is punched in the center with a 3 millimeter punch, and the cornea just serves as a sandwich with the back plate being put on the back. Like I said, you can use a PMMA backplate or a titanium backplate, and then this is locked in place with a locking ring if you're using a PMMA backplate. This is a wrench device that allows it to snap on to make sure that the back plate and the front plate stay attached. This is a different video of a different patient, but this patient has had previous failed grafts, and you have to kind of manage the blood vessels and determine whether you can peel off the graft. In this case, it was an old graft, so it required trephination, usually about a 0.5 millimeter smaller than the size of the keratoprosthesis. The keratoprosthesis back plate is 8.5, so this is an 8 millimeter trephination. You do have to be a bit careful in terms of how much hemorrhage blood you allow getting into the eye, because especially if they're aphakic, it will slow down the recovery, and then the graft is removed. This patient also has a glaucoma drainage device, as you can see, is pseudophakic, has a lot of scarring on the inside, and management of all of that is going to vary from patient to patient. You can certainly take the IOL out and use an aphakic K-Pro, or just use a pseudophakic K-Pro and suture it into place. Very similar to, again, a full thickness graft at this point. In some ways, it's safer than doing a full thickness graft intraoperatively, because once you have the back plate in, it provides a nice barrier to prevent things like a suprachoroidal hemorrhage. So the patient that I mentioned is somebody who I still follow and is now a patient of mine for 20 years and has maintained his 20/60, 28 to 80 vision from year to year when he comes back to see me for his follow-up. So in summary, limbal stem cell deficiency is primarily diagnosed with clinical signs and symptoms. SLET is certainly a viable option for limbal stem cell transplantation and potentially safer and cheaper than alternative techniques. Keratoprosthesis can provide an alternative for keratolimbal allografts and eliminate need for systemic immunosuppression. Thank you.
Any questions? I think we've already passed, well past our allocated time, so we will wrap up here. I'll give my talk some other time. Any questions to any speaker? If there are no questions, I would like Alvin to conclude the session by saying a few words about the presentations.
It was an excellent session. I've learned a lot, and very, very interesting questions as well. We all have our geographical differences and our local region things that we need to learn. So we should adapt whatever good points and bring it back to our center. And very, very good meeting. Congratulations, and thank you for inviting me again. Have a nice Sunday and the rest of the conference. Thank you.